Bismillah ar-Rahman ar-Rahim. I have to thank Janssen for giving me the opportunity and chance to be with you. وشكرا دكتور أحمد على الدعوة الجميلة وعلى يعني الاستمرارية، ودي حاجة مهمة جدا جدا جدا. ربنا يبارك لكم ويسعد أيامكم يا رب. Talking after Professor Nabil is something difficult. He showed you that these patients with metastatic hormone-sensitive prostate cancer, it's not better to go for the triplets rather than the doublets, except in certain situations. And I think that the choice of the doublet will be my aim today. So navigating doublet choices in metastatic hormone-sensitive prostate cancer. And before entering into the details of the doublets, we have to mention that patients with metastatic prostate cancer are usually living in two spaces. The first space is the space of the hormone-sensitive disease, and the second space of castration-resistant space. In the first space, the hormone-sensitive, it is very important to know that these patients are divided and classified according to the timing of the metastasis into synchronous and metachronous, with synchronous is having the worst prognosis. On the other hand, they are also classified according to the depth of invasion of the tumor in the body into either high volume or low volume, or high risk or low risk, according to the risk criteria you use it, with the highest survival rate for those who are having metachronous disease and low volume disease, and the worst scenario for the high volume and synchronous disease. Of course, when you are confronted with such patient, every effort should be done to try to prevent this patient from entering into the castration-resistant stage. Why? Because the mortality rate is higher there, and the quality of life is very low. These are the most important clinical trials controlling our decision-making in dealing with these patients. I mean, patient with metastatic hormone-sensitive prostate cancer. We have 4 molecules and a chemotherapeutic agents: docetaxel, the chemotherapy, the abiraterone acetate, apalutamide, enzalutamide, and darolutamide are the different ARBs. What is important to know is that look at the primary endpoint. You can find that the primary endpoint for all the trials is the overall survival, except the ARANOT study. And look at the hazard ratio of the overall survival. You can find it all of them had statistically significant improvement in overall survival. We are talking about ranging the hazard ratio from 0.6 to 0.8, except the ARANOT study, in which there was no survival benefit. Focusing on the survival data of the ARANOT, ARCHES, and TITAN. In the ARANOT, the addition of darolutamide to the ADT improved survival, but it didn't reach the level of significance. In the ARCHES, the addition of enzalutamide to the ADT was associated with 34% reduction in the deaths compared to placebo, and it was significant. And in the TITAN study, the addition of apalutamide to the ADT was associated with 35% reduction in the risk of death when compared to placebo, and it was significant. With more and more maturation of the data, and after correction of the different crossovers, very clear in the ARANOT, no survival benefit. In the ARCHES, 36% reduction after correction of the 30% crossover. And in the TITAN, nearly 50% reduction in the risk of death after adjusting for 40% crossover. The ARANOT study is a non-USA study. This is very important, and it was not done in different European countries except a very few, mainly Asian, Canada, and some South American countries. Important notification in this study: this is a comparison between the placebo arm in the TITAN and the ARANOT. You can see دول الاثنين اللي اخذوا زولادكس هنا وزولادكس هنا. You can see that the incidence of adverse events is doubled in the TITAN compared to the ARANOT. This is something to be considered in your mind when you are reading in between the trials. يعني ده واخد زولادكس وده واخد زولادكس, والincidence for example for the fatigue 8 versus 16%, الفولز 0.9 versus 7%. This is something to be put in your mind. And these are the most recent NCCN guidelines 2026. Level 1 evidence for abiraterone acetate, apalutamide, enzalutamide. But other recommendations for the darolutamide. This is the EAU guidelines 2025. You can see clearly that offer ADT combined with darolutamide in patient with metastatic hormone-sensitive disease is having a weak agreement. So, of course, we are not going to give this patient monotherapy. We are not going to give this patient chemotherapy alone if we do not have, except if we do not have the opportunity to have one of the ARBs. And as you can see that darolutamide, there is inconsistency about the level of evidence that it is present in the different guidelines. So how can we choose among the other options that we have? Maybe the type of the metastasis at presentation may help us. You can see here that the 𝐼𝐠 study, and this is very important subgroup analysis from the visceral metastasis, the addition of the enzalutamide to the ADT in patient with visceral metastasis, there was no overall survival benefit. Look at the low volume. The low volume, there was an improvement in the overall survival that didn't reach the level of significance. انزل تحت على الانزيمات وبص على الميتاكرونس هتلاقي still there was improvement in the survival that didn't reach the level of significance, and this was published in the ASCO 2025. We are talking about low volume synchronous disease. The addition of enzalutamide improved the survival, but not to the level of significance. On the other hand, we can see the data of the TITAN. Apalutamide, when added to the ADT, showed improvement in the overall survival in both high volume and low volume, in both metachronous and synchronous, in patients who are having the worst prognosis, synchronous high volume, or those with high number of bone metastases, more than 10. You can see here clearly that there was a 32% reduction in the incidence of risk to death with the use of the apalutamide for those who are having synchronous high volume metastasis. It was 46% reduction with the use of ERLEADA in those with more than 10 metastatic sites, 40% for those who are having between 10 and 20 metastatic sites, and 47% in those with more than 20 metastatic sites. Thus, we have a drug that is working in all subgroups with a magnitude of benefit that is increasing with the aggression of the disease, and this is very important. Another important point is that it was also capable of achieving the same endpoints significantly in the other secondary endpoint. What about the PSA decline? Clearly, as you can see here, the ERLEADA took the PSA decline to another level, to the level of ultra low 1 and ultra low 2. 70% of patients receiving ERLEADA had reduction in the PSA to ultra low 1, and 50% had taken the ERLEADA, or those receiving ERLEADA was achieving ultra low 2, and ultra low PSA 2 means 0.02. So this is less than that. So this is very important. Does that reflect on the patient? Yes, clearly from this meta-analysis, you can see that these patients who are achieving ultra low 1 and ultra low 2 are having the best prognosis, irrespective to the patient subgroup. irrespective the patient كان جاي de novo metastasis ولا البيشنت كان عنده metachronous, irrespective of the volume, high volume or low volume, and the faster time and the deeper PSA decline with the apalutamide correlate with longer survival. What about the real-world data? We have two important trials, the ROME study and the PROMPT 1. These are not prospective studies. These are not randomized studies. These are retrospective data. But this retrospective data compared the apalutamide and enzalutamide. And as you can see, after a median follow-up of 2 years, 24 months, there was a 40% reduction in the risk of death compared to enzalutamide. Look at the PROMPT 1. PROMPT 1 is measuring what's known as PSA 90. It's the ability of the molecule to decrease the PSA more than 90%. You can see here clearly that it took from the apalutamide 3.7 months to do it compared to 5 months for the enzalutamide. What about the APA versus the abiraterone acetate? The same. 40% reduction favoring the apalutamide over the abiraterone acetate, and PROMPT 2, as you can see, 6 months difference. It means 3.7 months to have PSA 90 versus 10 months for the abiraterone acetate. What about the cardiovascular comorbidity, which is very important? This table is demonstrating to all of us the level of cardiovascular abnormality or adverse events. In the abiraterone acetate is having the highest one, followed by enzalutamide, while the apalutamide and darolutamide are having the lowest cardiovascular events. This was confirmed in the meta-analysis. Again, you can see clearly that we are talking about the ABI here, the highest incidence of cardiovascular mortality or morbidity, I'm sorry, and the ENSA also, while for the apalutamide, no statistically significant risk increase with the use of this drug in these patients. Another meta-analysis clearly, يعني ما توجعوش دماغكم، بص هنا بس كده الريسك ريشيو، انزالوتامايد ريسك ريشيو 1.9، abiraterone acetate 1.5، apalutamide 1.4 and darolutamide 1.3. So we are talking about APA and darlo as يعني the least molecules with the adverse events. This was a very recent publication in the last year, in 2025, in the ASCO, the efficacy and safety of apalutamide in metastatic castration-sensitive prostate cancer patient with prior history of cardiovascular or metabolic risk factors. اللي دخلوا الترايل وعندهم الكلام ده. Actually دول كانوا 70%، clearly اللي استفادوا نفس الاستفادة من اللي ما كانش عندهم cardiovascular problems، و clearly برضو ان ال degree of side effects كانت على حاجة خفيفة، and this was attributed to the use of the ADT rather than the apalutamide. آخر حاجة هنتكلم عليها هي ال strategic thinking when extending the lines of treatment, and this depends on your concept or your understanding of what is known as PFS2. ال PFS2 is the time from the randomization of the study لحد ال progression على ال subsequent line اللي بعد ال investigational agent اللي انت بتشتغل عليه. And this was clearly higher in the apalutamide when compared to the placebo. وده مش كده بس، ده whatever the drug you used as a subsequent agent hormonal therapy، لان تقريبا منهم حوالي 25% اخذوا abiraterone acetate or taxane حوالي 30%، there was an improvement للأبا على البلاسيبو. ده معناه ان الاكستند بتاعه او الافكت بتاعه was extending beyond the discontinuation of this drug, either hormonal or taxane, same risk reduction achieved. وحاجة تانية كمان مهمة جدا تفسر ال PFS2 هي الانسيدنس اوف ذا ابريجنز اللي هي اندروجين ريسبتور ابريجنز. طبيعي واحنا بنستخدم الاي دي تي هيبقى في ابريجنز بتطلع علشان يبقى في ريزيستنس. لما احنا نستخدم الكلام ده بلاسيبو من غير حاجه اي دي تي الون، زي ما حضراتكم شايفين كانت 23% بقت 67%، انما لما استخدمنا الابالوتامايد زي ما حضراتكم شايفين 20 طلعت فعلا زادت، بس زادت ل 48%، يعني معناه بيقلل الابريجنز اللي بتيجي by time, and this explains the improvement in the PFS2 اللي احنا شفناه. وبالتالي احنا دلوقتي لو استخدمنا الابالوتامايد كفيرست لاين، الابالوتامايد احنا عارفين ان هو مش بيستخدم في الكاستريشن ريزيستنت، وبالتالي انت بتوفر لاين ممكن تستخدمه في الكاستريشن ريزيستنت. وبدات بالارليدا يبقى وعندك 3 اوبشنز A B و C، هتستخدم الاي بي وسي بغض النظر الترتيب بتاعهم ايه، انما لو بدات باي واحد فيهم A or لوحده او B لوحده او C لوحده وسبت الارليدا later on you are not going to use the erlida and you are going to lose one line. So if we started with erlida, we have the options of abiraterone acetate, enzalutamide and docetaxel. If we started abiraterone acetate, we have the options only of enzalutamide and docetaxel. If we used enzalutamide, it is abiraterone acetate or docetaxel, and if we use the docetaxel, it is abiraterone acetate or enzalutamide. And this is my last slide. The synchronous and metachronous diseases of metastatic hormone-sensitive prostate cancer differ clearly as regards to the prognosis. ADT alone is no longer available in the guidelines. ADT in addition to chemotherapy is no longer a treatment يعني إلا في حالة فقط إن أنت مش قادر توصل ل one of the ARBs. The network meta-analysis suggests that there is no added benefit from the triplets when compared to the potent doublets. Apalutamide provides deep and rapid PSA decline with maintained quality of life. Apalutamide is an extra hormonal treatment allowing you to save more lines of treatment for later stages. And thank you for your time.
Thank you to Mohamed.